Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks.
Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor for me to introduce Dr. Howard Gluckman. Howard, thanks for being on the show today.
Thanks for having me, Philip.
Yeah, and I know you're joining me from Cape Town, South Africa, so I appreciate you making the long journey on the internet, talking with me. And it's 1:00 p.m. my time, and it's 8:00 p.m. in the evening their time. Is your time? Is that correct?
That's correct. Yeah.
Okay. Well, for people that may not know a whole lot about you, I know you've got a pretty reputable name. Why don't you tell people a little bit about your dental training, kind of little bio about yourself and where you're working now and teaching and what you're up to.
Perfect. Well, in essence, I'm a periodontist. I'm a specialist in oral medicine. In South Africa, we have to specialize in both oral medicine and periodontics. So I'm a specialist in both oral medicine and periodontics, which I qualified in 1998 at the University of Stellenbosch in Cape Town. Obviously, I'm a general dentist as well, as is everybody before they specialize, which I did at the University of Witwatersrand in Johannesburg in South Africa, and I qualified there in 1990. Subsequent to that, I've always had a passion for surgery. I've always had a passion for implants, and it was kind of a natural progression for me to travel around the world and go and spend time in some of the best surgeries around the world, learning the skills of bone grafting, learning the skills of soft tissue grafting and stuff like that. And essentially, I suppose I would say I have an inquisitive mind, and I like to push the envelope quite a bit. And I kind of have always tried to expand and push and kind of develop as much as I can. I found a lot of times through the years of my training, or through the years of working, that things that were told to me and sold to me and didn't really work the way the articles, the publications, the science, and the people who were supposed to be in the know told me it would work. And I used to think that there was something wrong with me until one day I realized that a lot of the times we were actually being lied to by a lot of top people and top publications. And when one does digging deeper down, I found that the data that some people were presenting was not as clear cut as I thought it was. And we started to then search for other things, which were more effective. And I suppose as a result of that, I do things a little bit less or maybe differently to the way most people do. I'm not as minimally invasive as everybody else tries to be, because I don't find the minimally invasive techniques as effective and functional and predictable as people would attest to. And the interesting thing is, the more I travel around the world, the more I see people having the same problems that I did, but being told by companies that all they had to do was add bone, add membrane, add salt and pepper, and they're going to get a fantastic result. But it just doesn't work out in their hands. So my search has always been for predictability and for achieving the best results that I can time and time again. I don't hit it. I hit it maybe 6 out of 10 times. I hit the perfection, and the 4 out of 10 times I don't. And I think that's the reality of dentistry and implantology. I'm also a very passionate teacher of implantology. I have an academy in Cape Town called the Implant and Aesthetic Academy, and you can see my Facebook page, and you can go to our website, implantacademy.co.za. And we basically run around 6 to 8 courses a year, taking people from basic implantology to advanced implantology with bone grafting and things like that. And essentially, if I look at my speciality, I'm pretty much maybe a master, a jack of all trades, master of none. Maybe, I don't know. But essentially, I think it's absolutely critical for anyone doing implantology to be both adept at doing both hard and soft tissue augmentations, as well as a firm understanding of occlusion, teeth, aesthetics, and how the teeth fit into the smile if you're going to be doing anything that's really, really of value. So I've spent a lot of time getting my techniques up to scratch and being able to get my results as good as I can, as often as I can, for want of a better word. So that's about it. That's me in a nutshell.
That's quite a bit. I'm definitely impressed with your resume, and you've got quite a background and a reputation. So I know we can learn a lot from you. I would agree. I think it's too easy to sometimes go and see the published literature and these presentations and think it's perfect every time. And if your dentistry is not perfect, then you're a failure. And I just don't think that's the reality. And I think there's a lot of challenges that you have to go through in your career, and you have to learn kind of what's taught, and then you kind of have to learn what's real. And I think those aren't always the same. And every technician kind of takes his own path and learns his own way. So there's a lot of neat things going on in dentistry, and I'm glad there's some people with some courage out there to kind of lead others and lead the change with where the field's headed. The topics I wanted to cover today are the partial extraction therapy topics. I know you've got a lot going on with that, and you told me those are kind of broken down into 3 categories. Why don't you share with me the categories of the partial extraction therapy, and we kind of discuss some of that as it relates to what you're doing in your practice?
With absolute pleasure. I think what I'll do first is just give you a little bit of understanding for those people who don't understand what the whole concept of partial extraction therapy is, because I think that's fundamental to explaining what we're trying to achieve. And for anyone who's done implantology for a number of years, you'll know that a lot of the cases that we have, they look great for the first 5 years, and then suddenly about year 7 to 10, things start to collapse. You start to lose soft tissue, you start to lose bone, you get resorption of the ridge, and everything that we've tried to achieve kind of goes up in flames. And, the problem is that we don't really know which case is going to go that way. We have some cases which do and some cases that don't. And that's the frustration that we have when we talk about long-term results and long-term aesthetic stability and things like that, which has really become the buzzword for implantology in any conference around the world. So partial extraction therapy really is a concept where we try and prevent collapse of the ridge over the long term. And the way we do that is by trying to fool the body into thinking that the tooth is still there, either by partially sectioning some of the root out or just sectioning the crown out and sinking the root, and really trying to just maintain the ridge dimension over the long term by keeping the bundle bone intact and keeping the periodontal ligament intact, which is essential to preventing the collapse of the bone. So the partial extraction therapy is really split up into 3 parts. And I'll start with the first part, which is the root submergence technique, because that is really the technique where everything stems from. Because partial root submergence technique is a technique that a lot of the older dentists who go back 20, 30 years will know that in the 1960s and the 1970s, this was a technique that was practiced very extensively as almost a pre-prosthetic surgery technique, where the root was submerged and closed up with gum and then allowed to heal so that the ridge basically didn't resorb, and then the denture went over that. And this has been something that's been going on. The first documentation was, I think, 1975. And then we went into vital root submergence, where we sunk the root without any endo, non-vital root submergence, which was done. And all of these showed great long-term results in stabilizing the ridge. And I think anybody who's seen a root that's been left behind by mistake in a lot of cases, you can still see that the ridge in that one area hasn't collapsed, which is really a fantastic result. In around 2007, Maurice Salama and Team Atlanta and Ishikawa did an article in International Journal of Peri and Restorative Dentistry, which really brought root submergence into mainstream implantology, where they showed the root retention, the specific root retention, and they showed phenomenal papilla maintenance, phenomenal ridge maintenance, and aesthetic results which were just second to none. And I think that's where everything stems from, because from there, Marcus Hertzler, who is the developer of the socket shield technique, he was a guy that really took it one step further and took root submergence and thought, well, hold on a sec, if we submerge the root and everything works perfectly, why can we not maybe section the root and put the implant behind the root and still leave the buccal portion of the root, have an implant behind that, and thus foxing the body again into thinking the root is still there, but having an implant behind. And that is where Socket Shield was born, where in 2010 he published some animal studies which showed that by cutting away a portion of the tooth, taking out the palatal portion, placing an implant behind, they showed in histological evidence that if you did that, there was zero collapse of the ridge. And on top of it, you also got bone formation between the root and the implant, which is what most people were concerned about. What actually happens between the two? Do we get soft tissue? Do we get bone? And the essence is that we get bone formation, which is fantastic. And it creates a little bit of almost like an ankylosis on the inside between the bone and the dentine. So essentially, in 2010, there was a Greek group that had been doing this technique for 10 years already. So in 2014, they brought out an article in JOMI where they showed 5-year data, which was quite nice, because now suddenly for the first time we had some long-term data. But the interesting thing about their data is they claimed 100% success with no complications, and there were no problems at all. But what the data didn't show was that they actually had a number of complications, because when they did the socket shield, they left the root actually exposed to the environment, which is not really what we're looking for. And over the years, we've kind of changed Marcus Hertzler's technique and the way they've done it over the years to something where we don't have any complications anymore, or not any, but as minimal complications as one can have. So the most recent article that's come out is a new article from Daniel Bomer, and he is from Marcus Hertzler's group. And they did a volumetric study of 10 cases that they started in 2010. So this was long-term data to show that when you did the socket shield, not only were there very few, if any, complications, because they had no complications in their group, doing digital, merge the two digital scans together to see if there was any loss. They actually found in one or two of them that there was actually a gain of tissue. So not only did they not get the buccopalatal collapse, they didn't get the vertical collapse described by Schropp, and really showing phenomenal stability. So this is really now something that's becoming a thing that's really, really taking off a hell of a lot. And essentially, we've changed the technique a lot to try and make it a little bit more user-friendly for everybody, and to try and make it more applicable in most people's hands, and also to try and reduce the number of complications that one can have with it. There aren't many, but we want to try and eliminate all technique a little bit. On our Facebook page, on our partial extraction therapy Facebook page, there are animations that we've done so that you can actually follow the technique and see how to do the technique to limit the number of complications. The third technique that is described in partial extraction therapy is called the Pontic shield. And the Pontic shield is a technique that I developed, and basically it was a combination of root submergence and Pontic and socket shield. And Pontic shield really is the merge of the two, because in cases where we wanted to do a root submergence, where there was apical pathology of any sort, it meant that we couldn't submerge the root. Or also in cases where you cut off the crown of a root and there's no bleeding of the pulp at all, because one needs bleeding of the pulp for root submergence to know that you're doing a vital root submergence. Because if the root is dead, or if the root is hyperemic, then one cannot actually sink that root without a successful root canal. So the question is, does one go through a whole root canal process, wait 6 months to see that the root canal has been successful, and then sink the root? And the answer was no. So what I developed with that was the Pontic shield, whereby we did the socket shield exactly the same way as one would do a normal socket shield, but instead of placing an implant, we would place synthetic bone, either xenograft, allograft, tricalcium phosphate. It really doesn't matter what type of bone you put in there, and then covering it up with soft tissue in most cases to get primary closure of the area.
Are you putting a membrane over the synthetic bone?
No, one does not need to put a membrane over at all, because remember, we're not trying to do any socket preservation and create bone, although it will probably happen over time. You will develop bone. But the essence is what we're trying to do there is just to prevent collapse of the ridge, and the Pontic shield will then keep that, and then you can do your ovate Pontic into that area, which will then allow you to get fantastic emergence profile in the area of the Pontic. So essentially, those are the three techniques that one uses for partial extraction therapy, and the results that we're getting so far after 4 years are just phenomenal.
Excellent. So you basically have a way to control the bone and a way to keep the facial and lingual bone from collapsing by using the PDL and the bundle bone from the tooth that was there and extracted. So why don't you walk me through the technique? Can you tell me, for someone who's never done something like this, maybe walk me through how would somebody approach this in a case, and which area would be the best place to try first?
Well, I think if one's going to do this kind of technique, the best place to work with it is on a patient who has a low aesthetic value, that's for sure, a low lip line, low aesthetic value, and certainly explain to them that you're either going to do a delayed approach where you're going to extract the tooth, wait for healing, do an implant, do some kind of contour augmentation that has been described by Danny Boozer, or we can do the immediate placement with socket shield and possibly get the best results that could be got. But if it does fail in their hands, they then go back to doing a delayed placement with a contour augmentation. So nothing's really lost, but the potential for getting a fantastic result is very, very high. So essentially, it's important to explain that this is the first one that they're doing. It's important to explain that if there's a failure, how they're going to progress with it and what's going to be done. And then do one in a patient with a very, very low lip line, with a very, very low aesthetic value. And I would generally do it in a premolar. Second premolar would probably be the best one because it has the right shape root. First premolar is very difficult because it has two roots mostly. So that allows people without it being actually in the smile zone. And then anyone with a low aesthetic value, where they've got 17 different what their teeth or something like that. So those are the areas that I'd look to start. But I mean, really in patients with low aesthetic value, you can really start anywhere in the anterior zone. I wouldn't go to the upper jaw. So for anyone starting to upper jaw, definitely low aesthetic value. And if you're worried, start in the upper second premolar zone.
All right, I think it's very difficult just over a podcast to give people an explanation, because they really need to see some of the animation or some of the videos that are online. And I think that's the best place to start, is to get hold of some of the videos online. There are also some training facilities in the States that you could go to. Dental XP is one of them, where they hold a number of partial extraction therapy courses. But essentially what one's trying to achieve is a small, thin, 2 to 3 millimeter thick piece of root that extends the line angle of the which then is around two-thirds of the apical of the coronal portion, as well as all. And what you want to do is you want to leave that root probably at the same level as the bone, and then you want to create at the top of the coronal portion of the root, which around 2 millimeters down, which allows what we call the prosthetic space. And this is very, very important, because your implant is placed at the base of that S shape, so that it creates space in the root for the crown to emerge from and for soft tissue to cover that root. If you don't do that, you end up with what we call an internal exposure, which means that you can have, which essentially exposes the root to the environment, which we don't want. We want total of soft tissue over the shield, and you want beautiful soft tissue to show, so it looks like an absolutely normal socket or a normal emergence of an implant crown coming from an implant. So I think the best thing to do is to have a look at those videos. It's very difficult on a podcast to describe step by step how to do it without actually seeing what we're talking about. Mm-hmm. Over to you, Philip.
Yeah. So what you want to do is section the tooth in half first thing, and then you would basically extract the lingual half of the tooth. Is that correct?
Correct. That's right. Yeah.
Okay. And then how would you go about reducing the facial part of the tooth that's still in there as it relates to the bone?
Well, essentially what you want to do is you want to have some kind of gingival retractor. And most guys have that little, I think it's from Meisinger, who have that little retractor that you use for composite. And you can utilize that gingival retractor, and you need a round diamond burr, which will then just allow you to shape the coronal portion. I use long shaped round diamonds from Comet, and anything equivalent, it's around 2 millimeters in diameter, and it allows you to shape the coronal portion while retracting the gingiva. That gingival retraction is very, very important, because if you don't, you tend to thin the gingiva out with the drill, and you then end up with an external exposure of the shield, which is then something that one has to then do a soft tissue graft to close up if one has that. So the best thing, once you've sectioned, once you've taken the palatal portion out, you then will retract the gingiva, take a round burr, and slowly reduce the coronal section to bone level. Then you will create a small S curve in the top or coronal portion to create the prosthetic space for the abutment to come out. And once you've done that, then you can start to prepare your implant placement. And your implant you want to place as far away from the shield as possible, so that you allow enough space for some kind of synthetic bone material that will then stabilize any clot inside there to allow new bone growth to form inside. Now I'm over to you.
Yeah. Now, why synthetic bone material as opposed to maybe a donor bone?
You can use donor bone as well. I think obviously just to reduce morbidity in a second site, you would use more synthetic bone. But really, I don't think it really matters what you place there. At this point in time in our studies, we are actually placing tricalcium phosphate, because that resorbs faster than anything else. And because it resorbs faster than anything else, we know that in the future there will be whatever we see that's calcified. We know it's bone, and it's not some kind of xenograft that hasn't been replaced. But using the patient's own bone is absolutely fantastic, and there's no problem with that at all.
Yeah.
Over to you.
Now, how thin do you want to thin down the socket shield tooth? How thin are you looking for?
Well, that's a great question, because in the beginning, when we started doing it in about 2013, we started reducing the shield to around 1 millimeter, and that's where we had all our failures. And we found that the thicker the root, the socket shield, the better. Now we're looking for around 2 to 3 millimeters of thickness, and with that 2 to 3 millimeters, you don't have any flexion of the membrane, and it remains more stable, so we get less complications that way. So 2 to 3 millimeters is around the width of the membrane that we're looking for.
Okay, and how far down of the natural tooth do you want? You said maybe 2/3 of the length or of the socket. How far down apically?
Yeah, it's about 2/3 of the root that you want. So you want to take out the lower 1/3. You need nothing. You need at least 6 to 8 millimeters of shield, so that you've got good stability and the membrane is well held and tight and intact.
Okay. Let's say we get the perfect shape of our socket shield. We place our implant and we get good stability. We're quite a bit lingual. We have a gap there, and we're grafting the gap with something synthetic or tricalcium phosphate. What are we doing at this point? Are we temporizing? Are we covering up with a healing screw and getting primary closure? Obviously, we want to make a tight seal at the top. There's probably different ways to do that, right?
Yes, there are. I think there are 3 ways that one can do this. And the first way that I prefer to do is to actually place a a provisional crown if one can. And obviously that will be determined by the quality of the bone and determined by your turn-in torque and your ISQ levels using Ostel or any other type of ISQ device. And if I've got the ISQ of 75, if I've got over 35 newtons of turn-in torque, I will definitely place a provisional crown. Now, the reason I want to place a provisional crown is so that when I will know that I've got good soft tissue closure by the time I have got to place my final crown. And also it means that I can copy my soft tissue profile using a customized impression. And that way, when I get my final crown back, there's going to be no pressure on the soft tissue at all. And I know that there's no risk that my crown then goes down and puts pressure on the shield, which could then either cause the shield to become exposed, or it could also cause orthodontic movement of that shield, which is not ideal by any means. If one cannot put a provisional crown on, then the least that one wants to do around these in the areas where you have got in the aesthetic zone is you want to put a customized abutment. Now, a customized abutment really is a composite abutment that is custom fabricated to take up the shape of the extraction socket, but it doesn't have the crown on top of it. So the subgingival profile of the abutment, of the custom abutment, is exactly the same as a provisional crown would be. And then one can, again, when it's finished, or when it's integrated, you can then do a customized impression post using the customized abutment to make sure, again, that you get no exposure and no pressure on the shield. If one doesn't want to do that and one wants to close up, you can always do some kind of rotated palatal flap, or as some know it as a VIP-CT, a vascularized interpositional connective tissue graft, as described by Tony Sklar, or a rotated palatal flap is the other word for it. You can also use a free gingival graft to close up. You can use a buccal advanced flap. So there are multiple ways that you can close it and then do exposure at a later stage, doing a minimalistic type exposure to just expose the implant itself and then go into the provisional or final crown stage. Philip?
Yeah, great. I think like you said, those first two are probably the most ideal because you're already setting the stage for the next step. So from what I'm gathering, the exposure of the shield or movement of the shield are probably the two worst complications that you could have throughout the process. Is that correct?
Yeah. Firstly, if the piece of root that you left behind is mobile in any way, you cannot carry on with this technique. And the total contraindication is if you have no bundle bone on the buccal of the shield, it cannot stay. You have to take it out and go to more conventional therapies where you'll require bone grafting. So that's the key. The one thing where we have a relative contraindication is perio disease, but those are the two most. And again, the one that's key is a socket shield mobility. So if there's any mobility of that shield, it will cause an infection and you will lose all the buccal bone and you may even lose the implant. The second biggest complication, which is not a real major problem, is where you have internal exposure, where you've got not enough space between the prosthetics or your abutment and the shield. And as you need at least 2 to 3 millimeters of space between the shield and the prosthetic components. And that's why it's important to create that S shape, which will allow you to have that prosthetic space. But it's not really a major problem. A lot of guys don't even consider it a complication. I do. It's not something that I want. I want total health. I don't want something that's going to have any potential to cause a problem in the long run. So what we do in those cases is we basically raise a flap and grind the whole shield down. And in certain cases, we'll even use it to allow healing. The next type of exposure is what we call an external exposure, where you've left it too sharp, and as a result of the soft tissue folding over it, it actually cuts through, or you've actually drilled the soft tissue with your drill and you've thinned it out, and as a result of that, it perforates, although unbeknown to you, and that perforation will just get more and more with time. So in those kind of cases, again, we raise a flap, we cut the We cut the socket shield down further. We make sure that it's nice and smooth and rounded so that it doesn't cause a perforation. We take a soft tissue graft, we cover it and suture up. And those are really the main complications that one has. It's actually quite uncomplicated compared to other techniques. And certainly the data that we've got now, because we are bringing out a retrospective study now on 128 cases with up to 4 years follow-up, which we'll be hopefully be writing up at the moment and hopefully we'll be publishing before the end of the year. And of 128 cases, we had 5 implant failures and basically 3 shield failures. And I don't think so we had a success rate of 96% because of 2 of the cases where we had failed implants, the shields were still intact. 2 cases where we had both implants and shields, and where we did a contour graft with an implant at a later stage and everything worked well. And the other case, the patient opted for a conventional. In one case, implant, we raised the buccal flap, we did a debridement of the implant, and we did buccal contours for process. So that's still going. So, and we are also in the process of doing a multi-center study where we'll have over 500 cases with between 1 and 5 year follow-up. So that should be quite interesting to see the data from that. But I know from what we're looking at now, the success rate is very, very high.
So I guess one question I would have is, does the socket shield stay in forever? Is that something that's being left and it integrates as part of the buccal plate? Or that's never something that's going and being retrieved later, is it?
No, the socket shield is there to stay. Everything that we put in there, or the piece of root that we put in, everything stays behind. We don't take anything out in the future unless there's some form of complication. But essentially, so far with our data and with the Greek data, which is coming at 10 years, certainly nothing's changing, and there's no collapse of the tissue, and that shield is there to stay. The root submergence is there to stay, and the pontic shield is there to stay.
Yeah. So is the critical factor is getting that gap between the shield and the implant, enough room in there for the bone? Is that one of the critical factors you would say?
No, there isn't a critical factor. It's a feeling from my side. We're doing more animal studies in Spain at the moment to see if that is a crucial factor. But there are groups that say that it should touch the implant. I mean, the shield, there are groups that say that it shouldn't. I'm one of those groups that said it shouldn't. But the scientific and histological data shows that between the shield and the root, it's not a problem, whichever way you want to do it. But the most important thing is that there can be no pressure on the shield. So when you turn the implant in and there's any pressure, you are going to possibly cause movement of that shield, but the shield. So I would prefer not to touch it.
Yeah, you just don't want the implant to torque and dislodge the tooth shield, is what you're saying, correct?
Correct. It's a preference from my side, but certainly not. It's not anything scientific that we can show is absolutely crucial.
And on a side note, what implant system or what implants are you placing?
Most Megagen implants. I think in the States they're available from IDS. And the reason I like them is that they've got a very aggressive thread and give you good primary stability. And on top of it, they have a Morse taper connection or a cone connection, which is essential from a prosthetic point of view because you have the built-in platform switch, and which means you get, the prosthetic space is very well developed in the system. So from my personal thing, if I had to say what implant system should you use, it should be something, the bare minimum is a platform switch. A cone connection or Morse taper connection is ideal in my opinion. But, people are using pretty much anything and getting similar results. But from my point of view, the prosthetic space is where the most complications occur. And if you have a built-in platform switch and you have a cone connection with the platform switch, you're going to get a better result, and it's going to be much easier space to be.
So you would say the platform switch and the conical connection are the two preferred parts of the implant. Is that correct?
Definitely. There's no doubt about that.
Yeah. Now, would you say that you need something with aggressive threads for this procedure?
Well, I think the aggressive threads are purely from the point of view of being able to do an immediate provisional, which then allows you to develop your prosthetic space right from the start rather than having to do it at a later stage once you do an exposure. So it's great. Do immediate load, do immediate placement, and so it's something that's ideal for the way that I place implants.
Yeah, so the aggressive threads really just allow you to have the primary stability necessary in the extraction site to then go ahead and do the type of custom heel abutment that you're looking for.
Yeah, either the custom healing abutment or the provisional crown.
Crown. Yeah. So you prefer the MegaGen. Any particular implant with that? Are you doing the AnyRidge or what are you liking from MegaGen?
I use the AnyRidge exclusively. I don't use the Any1. I use the AnyRidge. I find that's the best system. And for me personally, I think it's one of the best developed implants. I don't have a contract with them, so they don't pay me any money or anything like that to say that. And that you can use pretty much anything that you want. But the few things that I'm looking for is, as I mentioned. And the MegaGen certainly has that. I
think we've covered most of the questions that I'd had. We talked about the root submergence, the Pontic shield, the socket shield. We covered some of the studies, talked about the specifics on how to reduce the socket shield, the general shapes, the kind of implants to place in there. Any other tips or techniques or last closing statements that you want to share as it revolves to anyone wanting to try this? Let's say they've got lots of implant experience, but no real experience with this. Where would be a good place for them to go? Like you said, you've got a learning center that you've got. Obviously, I would say that might be a good place.
Well, I think, as I said, the Dental XP Learning Center, there's a lot of, if you go to dentalxp.com, there is a huge amount of lectures. I give 2 lectures on partial extraction therapies. There are a couple of lectures which show you step-by-step techniques on how to do this stuff. So I would strongly recommend that anyone go and watch those videos. If you want to go to a learning center, there's Team Atlanta, Dental XP Center. They do hands-on training. We obviously do hands-on training in South Africa as well, but obviously it's a bit far for most people coming from the States. But a lot of people from Europe end up with us, with a few people coming from overseas, from the States, etc., and things like that. But I think, for most people, what's very, very interesting for me is that, a lot of people, Philip, tell me that it's this very tricky procedure and they don't think it's something that general people should do. And the interesting thing is that wherever I've seen people, and it certainly shows me a lot on our Facebook page, is that a lot of people are doing it, and sometimes not 100% perfectly, but they're still getting a great result, way better than they would get had they extracted the whole tooth. And for me, that's certainly an indication of a successful technique where it is reproducible by the masses. When one gets a technique where somebody publishes a wonderful result and everyone's clapping hands and thinks it's fantastic, but then when you try it, you can only do it 1 out of 10 times. To me, that's not a successful technique. And I think that's what the socket shield and the root submergence and the other PET techniques are showing, is that the average Joe is kind of taking to it, they're doing it, and whether they're doing it perfectly or not, they're still managing to get that's way, way, way better than anything that you could. And the nice thing about it is that the patient's not spending money on expensive materials. The patient's getting something that's done immediately, and you're not getting multiple procedures to actually get that fantastic result. And I think that for me is the crux of this technique, and why this technique in the future, I believe, will be so successful.
Yeah, that's great, because I think, like you said, if it's not reproducible, if it's not reproducible by a large amount of people, then like you said, it's just another unusable technique. But it's great that so many people are having such success with this. So it'll be good to follow its success moving forward as this becomes more mainstream, I guess.
Definitely.
So
I think it's a very interesting technique, and the interesting thing for me with I have now over 20 years of experience of placing implants, and I have to say I've been placing immediate implants for 18 years. So I see a lot of my long-term follow-ups, and there's nothing that I have seen that produces the shape and the contour and the maintenance that is as good as these partial extraction therapy techniques. I mean, it is mind-blowing. And that's what's so exciting about it, is that there's nothing, from the fact that you're getting papilla formation between two implants, you're getting bone retention between implants, you're getting no collapse, no resorption. And that for me is the most exciting part of these techniques. And that's where I think it'll continue to grow, continue to develop, and we'll develop better ways of doing it, and maybe using guided surgery and things like that to actually do it, more with more precision. But I certainly think that these are techniques for the future, and they will model our implantology through to the future.
Well, Howie, I think that's a good wrap for today. I'll let you get on with your day. I know you've probably had a long day at work, and I've got to go finish the second half of my day here. So I'll get this thing edited nicely and put it together and get it out for the people to hear all about what you're doing. And if anybody wants to hear more from you, you've got your dental XP programs, and you've got your courses at implantacademy.co.za, and I'll direct people to those resources and hope that people can follow you and the success that you're having.
They can also, Philip, email me with pleasure on docg@mweb.co.za. So that's docg@mweb.co.za. If they would like to contact me directly, or they could Facebook me, message me on Facebook, etc. With absolute pleasure. I'll be happy to answer any questions and help and guide wherever necessary.
That's great. Hey, I know you're a real inspiration to a lot of people, and I know you do a lot of good for the dental community. So I want to say thank you for everybody who's learned from you and that you continue to influence. So appreciate your guidance and you're willing to teach. So thank you for your time today.
It's an absolute pleasure, and thank you for having me on your podcast. It's really it's an honor and a privilege wherever and whoever. So thanks very much, Philip, and I hope people get something from it.
Okay, thank you. Have a great night.
Thank you. You too.
Bye-bye.
Keep well.